caregivers can be supported in providing for the safety and well-being of infants and children. When we planned this webinar with Dr. Katz and our team, we had lots of discussion about the importance of matching the correct services for parents and children and infants, that these interventions would target the kind of presenting challenges that families bring to your court, and that those interventions would have an impact on those challenges, a positive impact, in order to lead to better outcomes for children and families. As you know, these services include screening and assessment and triage processes to understand what interventions are needed to strengthen parental capacity and address the developmental needs of infants and children. Today's webinar will provide a framework to help your court teams assess the needs of families, identify which parent-child interventions are best matched to families, and provide timely and appropriate and coordinated services. The second webinar, which is scheduled for October 30th in the same time slot, 1:30 Eastern Time, 10:30 Pacific, will highlight the key components of effective communication and information sharing approach and examples from the field from court teams that can be used to improve systems of care. The webinar is supported by the Children's Bureau. The National Quality Improvement Center that you are a part of is an initiative from the Children's Bureau, a program of the Administration on Children, Youth, and Families at the Children's Bureau, and you all met Tracy Watkins, our federal project officer, at the All Sites meeting. A couple of housekeeping issues. If you're not able to hear us at this point, well, we have the conference line that you can see on your screen. You can call us into that number. You can also see on your screen an email to Michael Franzen should you have any challenges with logging on. FRANZEN@cffutures.org. If you're not able to log on, send Michael or Ashay an email, and we'll help you get logged on. Most of you are familiar with Adobe Connect, and you can see the chat feature to submit questions during the webinar. You will be muted during the webinar until we get to the discussion portion, but we would really like you to submit questions. We will open the lines up in the discussion component of the presentation, so we would like to invite you to make this interactive. We're really fortunate to have Dr. Lynn Katz present today's webinar, and the webinar on October 30th, so we invite you to take advantage of Lynn's expertise and make this webinar, as well as the webinar on the 30th, interactive by submitting questions, and then when we open up the phones to have a discussion, any questions that you have, and who knows, maybe I'll even ask you a question or two. It's my pleasure to introduce Dr. Lynn Katz, University of Miami. Dr. Katz is one of the subject matter experts for the National Quality Improvement Center, or the QUIC. Lynn was not able to join us at the All Sites meeting, but has graciously agreed to present these two webinars, and a reminder that Lynn is available for technical assistance to your courts. A little bit of background: Dr. Katz, who is a research assistant professor in the Departments of Psychology and Pediatrics at the University of Miami. She's the director of the university's Linda Ray Intervention Center for high-risk children ages 0 to 3 who were born prenatally exposed to substances and or were victims of child maltreatment. Since 1993, she has coordinated the program's comprehensive early intervention services for over 1,000 infants and toddlers and their families. She was the early childhood partner who assisted in the development and ongoing implementation of Miami's dependency drug court services for children and parenting, and has worked extensively with the National Drug Court Institute training of new family drug courts. And now she's worked very closely with Judge Cindy Lederman, who you met at the All Sites meeting as well. Lynn is also the co-author of A Child-Centered Practice for the Courtroom and Community, a guide to working effectively with young children and their families in the child welfare system, along with Judge Lederman. And with that, I'd like to turn it over to Lynn Katz to present today's webinar. Lynn?
Thank you. I'm happy to be with all of you today to talk about a subject that I know is very near and dear to all of our hearts, our ongoing work that we all do to make sure that the families that come into care and come through our provider agencies receive the best possible services and the best match for them. So let's continue, Ashay. So I'd like to start just sort of talking a little bit, for those of you who were able to watch the pre-webinar, just a quick recap. And for those of you who didn't, I'll just let you know what we talked about in that pre-webinar. We talked about a case where Ashay and I, Ashay being the case manager, along with me as a supervisor, were taking many things into consideration as we matched a mother, Mrs. Brown, a single mother, and her newborn baby with services. And we talked about the impact of such characteristics as her bilingual status, the fact that, in fact, she was a working single mom, some concerns that the child care program had talked about in terms of the baby's developmental delays at daycare. And we talked about the need to match her with a counselor at her substance abuse treatment program that she felt was a good match for her, and the ongoing feedback that we needed from mom on this case. Now, naturally, the sorts of conversations that Ashay and I had related to Mrs. Brown, a single mom, and her newborn, but I think we all can identify with more complex family systems where we are talking about a mother or a father, grandparents, grandmothers raising grandchildren, and how in a more complex scenario we might have brought that support system and that involvement of grandparents and dads into the conversation. But for the time being, we thought that initial video might ease us into today's conversation about matching services with needs. So let's begin. So the objectives of today's conversation, and I'd like to call it a conversation because we really would like your chats to come in, your questions to come in, and really make this a dialogue as opposed to a lecture. What we want to do at the end of the day, all of us, I know, we want to understand what is best practice for family-centered care. What are the rationales that we have when we look at our communities and we determine what our system of care provider network has available for families, and we want to be able to develop or maybe even refine the processes that we currently use where we know who our providers are, but we are trying really hard to take into account all of the family-centered needs that our clients need and to match them with the appropriate services. And I can only speak for us in Miami-Dade County about what a real challenge this is for us every day with every family that we are privileged to work with. We also want to talk a little bit about the referral process, and I'll put referral sort of in quotes if I might, because we do a lot of referrals to providers, and providers either accept the referral or put our client on a wait list depending where we are. And I know that in our office at the university, 12 different providers have 12 different referral forms, and we're trying to see if there's a way where we can come up with more of a universal standard that many of our providers could use over time so that we get the same information, but we don't duplicate what one provider's referral asks for as opposed to another. We'll talk a little bit more of that as we go on. We also want to deal with the really great imposing challenge of what is our rationale for the way we sequence the services for the adults in the family and for the children? How do we know, how do we determine what a dad should do first, what a mom should do first, what we need to start with in terms of looking at the children's needs across their developmental ages? It's always a challenge, and also part of that challenge is once we set up sort of a service sequence with all of the members of our core team and with our parent at the table for that sometimes we've made a mistake. Sometimes we need to back up. Sometimes the program that we referred the dad to initially is not a program he's ready for. So we want to talk a little bit about that and how that should be an evolving process. And then last but not least, what do we do when a program that we've sent a family to, the goals aren't met? They are not getting out of the program what we thought they would get, yet they've participated in a satisfactory way, but the program's curriculum or intervention have not, in fact, helped us reduce the risk that brought the child into care. How do we revisit things as a member of a team? Okay? All right. Ashay, I'll throw it to you for the first polling question.
Thanks, Lynn. We'll start with our first polling question. And the question is, do you experience the most challenges matching services for parents, children, or both equally? So you can use the pop-up that just popped up on your screen and please respond. We'll be broadcasting results live. So we have about 15 responses, close to 15 responses, and it looks like the majority, we'll leave it open for a second, but as of now, the majority are saying both equally. So pass it back to you, Lynn.
Thank you, Ashay. And I would say that resonates with so many of us. Keeping all the balls in the air, making sure that we are matching the services in ways that meet all the criteria that the adults need, and then looking across the developmental stages of the children are similar. So we're going to talk about that. Let's continue. So what do we know about best practices? If we start from looking at substance abuse treatment, we know that it is not something that takes place in a vacuum. It doesn't take place in a vacuum. It's most effective when all of the wraparound services are there at the same time. And I think that also often when we're talking about parenting, for example, we often look at the need to put parenting as part of a case plan, but what sort of parenting would that parent need? And is it a parenting program in your community that identifies the strengths that this parent may have and often does have, and then looks at boosting their strengths, but filling in the gaps in terms of their competencies, their degree of empathy, and those positive sorts of things. So addressing all of these issues is a real challenge, and I certainly, we would put 5 stars on housing. Housing is such an issue in our large cities, in our rural communities, where we want sober housing, we want families to be safe in their housing, and we have to think about who are the providers that we collaborate with that can help us build those housing options for families, often with children, as we move forward. And the last thing that I think is really important is the health aspect of that piece. I was recently talking to a mother in our program, and to my surprise, in terms of having an intake conversation with her, I thought to myself, gee, I wonder if this mom herself is on the autism spectrum. And I say that just as a developmental psychologist. And I went back and I looked through the file and I spoke to the case manager and I said, do we have any documentation about the developmental functionality of mom, because I was getting some vibes, if you will, that maybe she has some issues related to autism. And when we checked the file, there was nothing there. So we said to ourselves, let's back up here. You know, that we have to take a health issue like that into consideration before we start doing any sort of planning. Ashay, let's move forward. So we have this desire to help our families access the services that we know are evidence-based, the services that we know have effective outcomes when criteria for matching the parent with that program is delineated. But the linkages are often such a struggle to come up with the solutions that our families can access so that they can be their best selves. Transportation, I'm sure we could have conversations about transportation from now until doomsday, and I would be very interested if any of you on the call have really come up with some creative transportation solutions so that if your programs are in fact not located close enough to where your families live, and you're, for example, in a rural situation where public transportation is not at its best, tell us a little bit about how you've solved some of your transportation issues. In Miami, for example, linguistic variance is an issue, a challenge that we deal with every day, from the sense that we don't want to send a family to a program in Miami if they are Creole speakers, where the program is not delivered bilingually and doesn't have someone on staff who also speaks Creole in addition to English. So these are systems we've had to build. We've had to go out into the professional community and bring folks in and talk to them about working in the child welfare system as consultants, as co-facilitators in parenting programs, so that we can meet the adults where they are in terms of their cultural and linguistic needs. One of the things we talked about in the pre-webinar that Ashay and I did was gender match between our clients and those who we seek out for them as our providers who are there to give individual counseling and those kinds of interventions. For some of our parents, it is essential to them that they be able to choose a male or a female counselor, given what they have gone through, given their history, and given what makes them most comfortable. But what about the fact that maybe a provider can't offer both of those to that dad, for example? What do we do in those situations? In terms of child development and the stages of child development, these systems of care that children are a part of include quality child care programs, the early intervention system that your state has in place. Who does it serve? What are the state entitlements and federal entitlements? And how do we link our children before they become school age with the right process for universal screening, and if there are some additional needs, getting them into the right program, getting them into the right child care program. I know that one of the things that we worked very hard on in Miami was coming up and working with our foster care system in terms of placement of children in child care centers. We wanted those child care centers to be licensed. We wanted to look at whether the child care programs had the right adult-to-child ratios, and we wanted to do training out in the field, which took us many, many years to train providers to understand who that toddler was that they were caring for 8 hours a day, what that child had been through, and why that child was crying all day, rather than to be punitive or to have a negative response to that toddler. The last piece, of course, is geographic location, and capacity are your populations set up near where your providers are located. And that, again, links back to transportation. How do we bring those two parties together? And the big question about, are we asking our providers, what is the service you are going to be delivering? Is it an evidence-based service? Is it a service that has shown to be successful when paired with the right parent and their needs? And that is something that we are undertaking and have been for a number of years here in Miami-Dade County. We don't want families to just go to a service that calls itself parenting, but we as team members here don't have any idea what the parenting program is. And for each of these pieces, the linkages and the connections and the conversations that we are having with our court team, no matter what court team we have, what does that back and forth look like with our providers? Are we having high expectations for them? And do we hold their feet to the fire if, in fact, the feedback we're getting from families is that the intervention is not giving them what we need? We must have the families at the table equally. Next. So again, the match between needs and services, families and children need clinical services, economic services. Our collaborative partnerships can't be just in name only. We need to be sharing information because we have the right documents in place that say we can share information. We need to know what every provider is doing in terms of intake, assessment, screening. We need to integrate as much as we can so that the flow for that family is as much of an even flow to meet their needs as we can provide. So what's the relationship between children's issues and parents' recovery? This question continues to be part of the discussions that all of us are having in the child welfare system. We know that for some parents, recovery motivator is, I'm doing it for my children. I want to be a better parent for them. And their well-being is intrinsically linked to my well-being, my sobriety, and my capacity as a parent to care for them safely and to sustain that care over time through my ongoing sobriety. So we always have to consider three things. We have the needs of the children, developmentally, emotionally, their health and well-being, and we need to also realize that simultaneously we're doing the same for the adults who are caring for these children, but we also need to focus on what does the relationship look like between the adult caregivers and each of their children, not their child, a single child, not the monolithic notion that I can be for my children one sort of parent. Teaching parents how to differentiate between the needs of their individual children and also what the impact has been as they move through their recovery. So we've got another polling question. Ashe?
Thanks, Lynn. So here's our second polling question, and the question is, has your court been focused on children's services, adult services, or again, would you consider it family-focused? Okay, I know, so we're at about 15, and I know many of you are in rooms together, so that probably reflects the number that we're seeing, but the results indicate that the majority, about 61%, said they're more parent-focused. Surprisingly, no one said that they're child-focused, and then 38% said that they are family-focused. Back to you, Lynn.
Yes. I think that it would be very common for those of us who have come on to a new project to grow, if you will, the children portion of our court, that we would be saying that when we were still in a place where our expertise and what we've done and brought to the table has always been focused more on the parents, but we're sort of moving in the direction to decide how we simultaneously include the need for the children to be matched with services and those services to be developmentally appropriate. And when we say family focused, does that mean that we're also looking at the relationship piece of each of those parents with each of their children? And the fact is that when we focus on parent recovery, parenting, in quotes, is something we always want to look for, because improved relationship building and skills building and knowledge building for parents as they move through recovery are going to be essential not only for reunification to happen, but we want families to sustain their reunification, understanding that the child that they're reunified at age 2 will someday be a 13-year-old, will someday be a 10-year-old. And so the dynamics of our parenting programs should really look at all the developmental stages of children in anticipation of what will be the struggles as a newborn becomes a 2-year-old, as a 2-year-old becomes school age. And this is a lot for all parents to be able to focus on. At the same time, they are realizing as they become sober and they sustain their sobriety that parenting is something difficult. An example of that I want to share with you is the fact that for many years we did a parenting program, the Strengthening Families program here in Miami, as part of a SAMHSA grant. And we noticed that when we did a screening and we used something called the Parenting Stress Index, we use it as part of our intake to sort of see where parents were before they started the parenting program. And then we did the PSI, the Parenting Stress Index, at the end of the parenting curriculum. What we found out when we finished the parenting curriculum was everybody's parenting stress was heightened. So we didn't reduce stress while we did the parenting program. We increased stress in parents. And we thought, oh my goodness, our program has been a failure. And then we started to dive deeper into that data by having a focus group with the parents who had participated. And their responses, which might resonate with all of you who are listening, are, I was never sober as a parent. I didn't realize what parenting requires. I didn't realize what parenting support will mean for my 4 different age children. And you've enlightened me, but at the same time, now I'm really stressed, knowing what I need to accomplish. And, you know, my response to 1 or 2 of the moms were, I think that parents do have a degree of stress when they are working hard to meet the needs of all of their children to their best ability. But it was an interesting conversation that we had with SAMHSA, because somebody who would look at the post data and say everybody's stress got worse would say, well, that program wasn't really working. But the deep dive really helped us understand through a focus group with the parents that stress, good stress, is part of parenting. So that was interesting. Actually, go back for a second, because the other part of parent recovery is child well-being. And I think what's really important for us always to keep on mind with the children of varying ages in a family, we're focusing on permanency, we're focusing on safety, but we also have to think about how has this experience, whether the children remained at home, whether they moved into foster care, whether they were with a relative caregiver, what sort of emotional toll, no matter what age, have the children experienced? And is it something we're able to see, or does the child appear to be holding everything together? But what are the signs and symptoms we should be looking for that says to us the well-being of this child may have been compromised in ways that we didn't recognize? Okay, let's go to the next slide. So family-centered services, and it was really good to see those percentages of you who already would describe your programs as family-centered. Again, just to emphasize, family-centered services is simultaneously about parents' recovery and meeting the needs of children. And because permanency and reunification is just one piece. Have we, over the time that we've had the privilege to work with this family, have we helped them establish, build on healthy relationships between themselves and their children? Because if we haven't done that, we haven't given it the programs that help build this support, the programs that are evidence-based to build healthy relationships with families that are in recovery, we risk the recurrence of maltreatment, we risk relapse and sustained sobriety, and we know that the impact of the on and off again parents' ability to meet a child's needs creates additional impact on child well-being over time. So family-centered services are like a choreography. I've often described it as the game show host who has a contestant who is trying to spin multiple plates on multiple sticks at the same time, making sure that none of the plates fall off the sticks. And that is what we are doing as providers and court teams. And that is actually what we're asking our families to do. I remember a mother that had been in our program, and she had been in our dependency drug court, and she had really been just done beautifully over time. But the fact remained that her children of varying ages had really been impacted by their out-of-home experience, and one or two of her children had developmental issues, so they required being at a special education school or a program. And as the exit planning was being done for this mother, and she became more and more insightful about what parenting her children was going to look like as they were reunified, she was trying to balance in her own mind, how is she going to continue to work? How is she going to be involved in her children's school? How is she going to get child A to their special ed program and child B to their other program? And it all looked wonderful on paper, but what she said to us at our team meeting was, I think this is potentially too much for me. I don't want to relapse, but I need help. You need to show me from square one, how could I plan my day? How can I plan getting all the children to where they need to go? Please give me help on every little piece of what I'm going to need to do when it is myself and the children's father back home, still trying to work, still trying to meet all of our demands, but now we are reuniting with children with special needs. And really your heart goes out to her, but it lets you know that you have to backtrack. You have to talk about every piece of what it's going to be like living back together as a family and what those demands are going to be before you release those parents into the world of running their own family. Next. So again, for some of the parents who have been less participatory in going to their children's medical appointments, for example, for whatever reason, transportation, here in the state of Florida, we have children who are placed in foster care in Miami-Dade County, but whose parents live down in the Florida Keys. It takes hours for them to come up to visit their children. It takes hours for them to come up to go to a child's medical appointment. And I know that when our team meets, we say to ourselves, we need to be better at this, because there would be no way we could expect that when that family is reunified, that dad or mom has had the experiences needed to truly understand and be able, for example, to manage their child's medical care. So the parents continue to have a list of things that would help them, support them, build their knowledge, build their practical experience. And we as teams, I think, are always trying to meet their needs more appropriately, with less duplication, and in ways that are feasible to them. Next slide. Ashay.
Thanks, Lynn. So this is our third and final polling question. The question is, what is your greatest challenge in assessing for and identifying needs? And the response options are inconsistent screening and assessment process, information and communication with providers and partners, and the last one is lack of quality information about needs. Okay, so we're at about 50, again, we're at about 15 responses, and it looks like a majority are saying information sharing and communication with providers is the #1 challenge, which to some degree goes hand in hand with lack of quality information about needs. Okay, back to you, Lynn.
Yes, absolutely, and that's so relevant, because we want to talk even more about information sharing and communication strategies in the webinar that we have coming up on October 30th. So thank you for that feedback. It sort of resonates with what we're planning. So we know that our providers have assessment tools. We know that many of them have an intake process with an assessment tool. They collect intake data. And I'd like to suggest that your team start to think about what information do you get from each provider, and what is your best plan, or how would you develop a plan to take all that incoming information from each intake that is done for your family, and do you currently have a plan to be able to set it all out on the table, integrate it, look for themes that have been shown as part of the intake at different providers, so that you are really using that information to plan what your client needs. What does that process look like? Once each provider has done their evaluation, sends it back to you, what are the critical questions you're asking about the information you received? What duplication are you seeing across providers? And where are there questions that you would have asked a provider, but their assessments don't seem to answer those questions? Next, please. So asking the right questions. This is a thoughtful process that I'd like you all to kind of go back to your teams and think about. When you have an intake from a provider, when you make a referral, ask yourself, for the adults and for the child, what was the reason we were sending them to that service? And from the information that we received, do we have a sense that this provider is going to be able to provide that support, provide that knowledge to the family? What have we learned from that provider's evaluative intake? And are we still making the right choice? Is it still a good match for the family to go to that program? Is that service, from what you understand, is it strength-based and family-centered? Does this service, post-evaluation, still seem to be a viable match? Next. And then, are you happy with the quality of the information providers are giving you? Or do you think that that's a dialogue that needs to happen between your team and that provider in terms of, could they expand their intake? Could they use some additional evaluative tools for the families or the children that you're sending there? Is there a way to sort of have a conversation about whether they are able to feed back to you what it is that you need? And are there commonalities across referrals? When the information comes back to you, what we did in Miami, just as an example, after years of looking at different referrals, was to create a referral form for our parenting programs that every parenting provider needed to use the same form. So when the information came back to our team, every program was using the same referral form. You could find the information that you needed. Our judges and our teams gave input into their referral forms in terms of, we'd like to see you be able to tell us about A, B, C, or D, and we made it a very collaborative process. So the intake data that we got from the providers was more easily integrated into the decision making when we sat down with the families. Next. Okay, we talked a little bit about in the beginning about sequencing of services for clients. Maybe you would want to chat with us a little bit about, how do you decide what a client should do first? What are the time constraints that you face in terms of pre-case plan staffing based on the data that you're getting from the intake from the providers or any assessments you've done at your team? Who makes the decision? How do you make the decision to say, this is the first intervention that would work for this dad? This is where we should start with the child. Are you asking those questions? And can you discuss with anyone your rationale for the sequencing of your services? It is an ongoing dialogue and something our team should consider. Thank you. Next. So we all know what happens when there's a mismatch of a service. When we've thought we've done the right sequencing, sent the family to the right program, but we soon find out from the feedback from the provider that apparently that program we sent them to wasn't intense enough, was too short, didn't get to the goals when they took their test at the end. And so now we're faced with my goodness, that program's goals didn't meet the needs of the families. How do we triage? What do we do? A perfect example in Miami is we have some parenting programs that require the parent and the child to be together at the parenting program for one part of the evening, but transportation never seems to be able to get the child to the parenting program for the portion of parent-child relationship building. So we have a problem. We had a goal. We sent them there. It's a mismatch. It's not achieving what we want. In fact, this is going to impact the timeline for our case. So how does your court make a decision that a program isn't working for a parent, we need to change the service, it isn't working for the client, we're working on a timeline, How do you do it, and how do you incorporate your parent attorneys and other folks who are going to ask, why do we now need to send our client to yet another program? Next. So all of these want to do's, all of these wish list pieces that we've been talking about have challenges, and typically the challenge is the access. The appropriate system is in this part of the county, but the family lives here. Transportation may be an issue. We need creative solutions. How do we use our foster parents and our relative caregivers to help families access and get to what they need to go to? How are you as a team building family support systems? Never assume in a family that if someone says, this person helps me out with the kids, that help me out with the kids piece really implies the piece that mom or dad needs to get to their program. So we always have to drill down, talk to the members of our families as they come on board and want to support the mom, the dad, and the children. Sit down and figure out what can they provide in terms of concrete support, nurturing support for that family. Don't assume anything when someone says, I have a support system. Next. So this discussion has been a lengthy one, and it's really just sort of to open that Pandora's box about what we know and we can all commiserate when we're trying to match services with families. Everybody on this phone call wants to achieve the best match between what the client, adult client, and the children need to reduce the risk that brought them into care or brought them into the system, and we want our programs to be effective. We want to be able to create sustainability of success for our families so that even when permanency is reached, we can breathe a sigh of relief that what we've put in place can continue to sustain the process for that family so they don't re-enter care. We want to examine how do we decide on what the sequence of services and interventions needed by the adults in the family and the children are, and how do we sustain it? How do we change it up if need be? And how are we ongoing involving client feedback into all of these processes? We have to expect that all of our services, no matter how good, may or may not result in the outcomes that that program was designed for. So what are we going to do in those eventualities to come to that decision, regroup, not waste the client's time, get the team on board as to why we're making a decision to triage that family or that child into yet another program that may be more effective. And that includes having our judges on board and our case managers on board when we have this process going. So with that, as Ken has indicated, maybe you have a comment. Maybe you would like to speak to any of the tasks that we are all charged with as court teams. We'd be happy to hear it. I also think, Ken and Ashay, you are going to include my contact information. I don't know if we did, but sometimes folks want to ask a question about a particular case or a particular family without going into details, and I'm happy to field those via email after this call. Ken, is there something you'd like to add in our last minute?
Sure. Yep. We do have, at the conclusion of the webinar, we do have your contact information.
Good.
If folks would like to contact you, or you can also work through your change liaisons to ask Lynn or shoot her an email directly. We're going to open up the phones, and while we do that, one of the things that resonated for me, Lynn, when you talked about standardizing the referral information from Linda Ray Center, and I recall working with a jurisdiction in another state in a fairly, not a real large county, and child welfare office, and they had a file cabinet of probably 8 or 9 different referral forms with different releases of authorization to release and obtain information, because each of the providers required that information on their own letterhead, on their own form. So they had to understand who they were referring to and then pull out the right referral form and the right authorization to release and obtain information. Some of the work that we do, and we can help all the sites, all the quick sites, is to really think about standardizing the referral information that comes from child welfare or from the court to provider agencies, so that information is consistent, and then standardizing the information that comes back from an assessment or that comes back from a progress report for services. And it doesn't necessarily have to be on the same form, but the content, the outline of the content is the same for the court as well as for the team, to understand the progress that's being made for a parent's participation in services. And that's, it gets to systematizing that work and not making it just contingent upon individual workers or individual providers. And so I think that's an important piece. I was also interested to see that the information sharing was one of the most significant challenges in working with providers, and that goes to I think part of what we're talking about here, that some of the uniformity and standardization of both the information that providers receive. It's important that they get that information in order to make valid assessments, and then the information that comes back from providers in terms of assessments, as well as how families are doing and progressing in their services. And we can certainly work with sites on all of those things as well. I'm just going to open up and see if there are any questions, and we're unmuting the phones at this time. Lynn, one of the questions that has come in to me on the chat is if you could talk a little bit about challenges that you encounter or have encountered in the work that you've done at the Linda Ray Center in terms of having infants or toddlers, young children assessed for developmental services. I believe I remember that you also are a Part C Individual Disabilities Education Act provider as well as assessor. Can you talk a little bit about that and what courts and agencies might, particularly child welfare, might experience in trying to access those assessments and services, particularly for this population of infants affected by prenatal substance exposure?
Absolutely, Ken. I think what our individual court teams would bear well would be to investigate in their state what is the framework for services for children at risk for developmental delays. In some states, the school systems for a given county are responsible for taking referrals where there are some concerns about a child's development. In some states, hospitals or the healthcare system does that. So having an initial meeting with whoever it is who controls the framework of services under the Individuals with Disabilities Education Act, IDEA. Every state interprets that at their state level in terms of what are their entitlements. What is it that families are entitled to? Where are those services provided? What is the portal to request screening and assessment through those services? Once that's established, I would suggest to a team that you have a brown bag lunch, that you have a meeting where they learn about what it is you do, they tell you what they do, and you start to figure out the best way to utilize what your state has provided in terms of entitlements. We have instituted some basic screenings that are done by case managers that don't require a clinician to do them. Our lead child welfare agency helps us manage that in our system of care. But the fact is, coming to grips with who manages the federal to the state entitlements for young children who are not yet in school, not yet in kindergarten or first grade, where it's the responsibility for the school to manage special education, and to create a relationship with those folks by bringing them over to your team or going to their offices. They do a presentation for you, you do a presentation about what your goals are, and then you start to create those baby steps where you connect the dots so they can be a portal for that screening and assessment. And I remember back 10, 15 years ago when we first had those meetings here in Miami-Dade County, and we said, what do we need to do to send you a referral? And how will that referral be handled? And who is the contact person? And what are the criteria for a child needing the services? So that starts with building relationships. By having those folks come over, everyone explains what they do, and then beginning to chart a path to make that work for the children and families, Ken.
Thanks, Lynn. Lynn, one of the participants is asking, could you talk a little bit more about the information sharing that you developed, the Linda Ray Center, with other organizations? I think both in terms of what you described as kind of standardizing your referral information, but also in terms of what you get back when the center refers a parent or a child for other services in the community. Can you talk a little bit more about that, what that looks like?
Absolutely. Well, one of the ways we began this process, we had our judges at the table, and we said to the judges, tell us a little more about the kind of information that is helpful to you. We had case managers at the table, and we said, what is it you need to know? Why are we sharing this information? You need to know about the current status and functionality of a given child or a given parent. You need information about triaging to other services, what is available. Let's sit and look, as you said, Ken, let's look at the forms that we all use for consent to exchange information that our families signed. How can we standardize that you are listed as an agency of record on my consent form, and if the parent checks that box on the consent form, because we talk about I'd like to have a conversation with that treatment provider, not about your case, but about whether their meetings meet your schedule for work. Would you be okay with checking the box that says I can speak to the village treatment program and talk about when you're available for your AA meetings and when their meetings are available? So we created consent forms that had limitations, but they were consent to exchange information, and we said let's have all of our agencies be the options that a parent can check in terms of us exchanging information, and then let's all use this consent form. And if we have to put the logos of all of our agencies on it because it encompasses what you need to know, what I need to know, let's put our logos on it and let's agree to its limitations, but let's have it be filled out one time and know that if a parent consents and signs the boxes, I'm going to send you a referral form that's the same one you use, but you're going to see what it is I need from your agency. It starts with building the relationships. Everybody brought their referral forms to the table. Everybody brought their consent to exchange information forms to the table. And we would meet regularly until we could really chop out a form that pretty much met everybody's needs. And we said, effective November 1st, folks, this is going to be the universal form that we're all going to use. Great,
thank you. That no small task, and
no, it can take a year.
Like Miami-Dade, with lots of agencies and providers.
Yes,
sure.
Yes,
sure.
And that's okay, but it's a process because it will result in the reduction of less duplication, more expeditious sharing of information, but first establish the relationships where nobody has to sacrifice what they need. And also, we also always had the court involved in creating our integrated forms. judge what is it you're going to need. What would you like to see on that form?
Okay, thanks. Here's a question around 42 CFR. What do you do when the state 42 CFR requires a specific form that it cannot be multiple providers on one form? It's an interesting question, Jeanette. I noticed I can cheat. I can see that you entered that question. If you don't mind me mentioning your name, I guess I didn't give you much of a choice with that. But it's an interesting question because I did some technical assistance in the state that required that, and I went to the state office. It's interesting because it's not required in the federal regulation. And if you look at the guidance that comes out of the Legal Action Center, you can have multiple providers on one authorization to either obtain or release confidential information. And for those of you that don't know, I think probably everyone's familiar, 42 CFR is the Code of Federal Regulations for confidentiality regarding substance use disorder treatment. And so either the federal regulation and then the interpretation of the federal regulation provided by the Legal Action Center in New York, which is really the foremost national authority on providing technical assistance and interpretation of the federal confidentiality regulations for substance use disorder treatment, allows multiple providers to be put on the form. So I was unsuccessful in talking to a particular state about moving toward a universal authorization or at least following the guidance from the Legal Action Center, and was not successful in doing that. So if your state regulation requires that the form be on a particular provider's, only one provider release, if you will, authorization, I'm not sure there's a whole lot you can do about it. Unless you could get the providers together let's assume it's a county, local jurisdiction, and that you could reach agreement as Lynn just described, and then perhaps go back to the state and see if that would be acceptable. You have to understand whether or not it's a practice that has evolved over time, or whether it's actually in a regulatory document, whether it's in fact in an administrative code or operating or formal operating procedure. But I would try to first work it locally to see what kind of agreements you can reach locally, and then double back to the state office to see if you can get concurrence there. In the context of QUIC, with some of the involvement of the Pathway 1 applicants with state partners, if you're in a state that has a Pathway 1 applicant, and even if not, we'd be willing to assist to try to engage the state offices to have that discussion. Again, it depends on how codified it is.
Wow, that's really helpful, Ken. Thank you. Thank you. I'm looking at a chat there from Shana. And I want to say, Shana, we experience exactly what you are describing here. And that often happens, that we do the Battelle screening on a child, which is our state of Florida tool that we need to use, and the baby is 3 months old and we can't really capture the delays. We do exactly what you've laid out here. Thank you for explaining your process. And what we might do 3 months later is an ages and stages screener on the child, as opposed to a full evaluation. It may, in fact, the ages and stages, both the basic ages and stages or the one for social emotional, it might start to capture a delay that is sort of trending that way. And it gives us a document to have in between the time that the child didn't meet criteria and 6 months later when we are hoping the delay will show up, as you say, and sending them back to early intervention. So we don't feel that using the ages and stages 3 months later and then 6 months, at 6 months before we send them back to early intervention, it isn't, it doesn't really have a practice effect, and at the same time it can show us if things are trending in the way where we think this baby may meet criteria. But everything you said is absolutely right. Thank you for sharing.
So that the question that that was posed, Lynn, right, was what happens when we send an infant or a toddler that doesn't show a delay, and that's what you were responding to.
Yes, yes. Having home visiting going on, keeping their eye on things, providing those stimulating activities, and having that going on, and then 3 months later we do an ages and stages, then we would do it 3 months after that, and we could sort of pair that with the initial Bailey, but say it's trending in a delayed trajectory.
Thanks, Lynn.
Yes, sure.
I'm going to take a positive risk here. This is, you know, we're more or less we're among family here, certainly among our own learning community, quick learning community. So I'm going to put something out there, and I may not get a response at all, but I'm going to put this out there, and recently on a site visit, so it kind of dawned on me this question, and that is that for some of the family drug courts out there, perhaps some of the safe baby or early childhood courts where the dependency case for your families is being heard in a separate court from what you're focusing on in your specialty court. And if that's the case, how do you share information about the services that that a family may be receiving under the jurisdiction of another court? So I'm not asking about the progression in the child welfare case, for instance, if that's handled in a separate dependency court, but how in your court, in your judges and you as a court team, how do you get information about the kinds of services that a parent or a child might be receiving in that is facilitated or made available in that other court that may not be directly being provided or facilitated or referred from your court? And I want to throw that out there and see if anybody's willing to talk to us, to share with your colleagues about how that information might be shared across your court with a dependency court that would be handled by another judge. I was afraid this would happen.
There's an answer from Karma.
Yeah. Somebody's typing. Okay. All right. We're gonna. You know how we're gonna get the answers when the consultant liaisons and the evaluation liaisons have calls with you, and when we come on site, we're gonna ask if that's an issue for your courts and talk about that, because the information sharing around services and progress being made around those interventions, in the context of what Lynn talked about the importance of understanding how those services are having an impact on the risk factors or strengthening protective factors for these families, that is so important, even if those services have been provided under the jurisdiction, if you will, under the work of a parallel court. So here's a question. Oh, thanks, Karma. Here's a response to my question. Thank you, Karma. We share information back to the dependency judge and all parties through a summary report. If you'd like, Karma, you'd be glad to. I think your phone is open if you'd rather speak to it instead of typing.
Can you hear me?
Yes, we can hear you. Yes,
oh, okay.
Thank you.
It's a little scary. Okay.
Yeah, I know, but yeah, we're among friends.
So we to share back, we have a summary report from every hearing, and after every hearing that goes to all parties so they know what we're doing in the drug court and the participation there. And then we try to get as much information as we can from DCS and the service providers about what else is going on, but it can be very difficult to get that information timely.
Sure. Yes, timeliness, yeah.
Thanks, Karma, for that. Any other questions? Let us encourage you, if you have questions that come to you after this webinar, feel free to send that through your change liaisons or through your evaluation liaisons, or you could send us you can just send us an email to the quick email. If you could go down to the last slide, then we'll come back to the webinar series. But if you get into the last slide, as I say this, how you can pose additional questions if you need. We'll just show Lynn's contact information on the last slide.
And I would ask a question for our participants to potentially think about when they talk to their liaison. When, if any time, do providers appear in court and talk about what's included in their summary reports? That they actually make an experience, have an experience of coming, and the opportunity as a provider to actually share the information that's in your report, and also for your judge to be able to ask you questions. So I'm curious as to the frequency in which actual providers not only send reports but appear in court. So I'd put that on the to-be-answered questions in the future, Ken.
Sure, thank you. And I would add to that then also the kind of the pre-court or the staffings that often occur prior to hearings, and certainly in family drug courts, and that level of participation as well. Can we show Lynn's contact information on the last slide, folks, at home? Keep going, and we'll come back to this. Keep going while I'm on a roll here. There it is. So if you have questions for Lynn, Lynn's graciously agreed to field any emails you have. If you want to reach out to Lynn about any of the things that she's talking about. Certainly the years of experience in being the director of the Linda Ray Intervention Center and partnering with dependency court. I know she's had to work very closely with Judge Lederman's court, very closely with Judge Jerry Cohen's family drug court in Miami over the years. So Lynn has a wealth of experience in working with the court and also being a provider for children's and preparing child interventions and well-renowned in that respect. So we'll go back and remind you of the webinar series. So we'll go back to the second part of this webinar is going to focus on one of the significant challenges you identified in your polling question. That is around communication and information sharing. And that webinar is on October 30th at 1:30 p.m. We encourage you to invite other team members or even partners that haven't come to the All Sites meeting or may not even coming to your team meetings, but feel free to invite other agencies from your community that you're engaging with as part of your quick. Encourage them also to view the pre-webinar recording. That was kind of a new initiative on our part, Lynn and Ashay's innovation, if you will, in order to portend what the webinar series would be about. So we encourage you to invite other folks who weren't available for this webinar to view that webinar and be welcome to come to part 2. There was also a question. We are going to post this recording on the quick web page, and we'll send out the link so that if folks wanted to who aren't able to be here today, we'll have access to the recorded webinar as well. We're also planning upcoming webinars as part of our technical assistance to you all. November 28th, SAMHSA is going to present a webinar on 42 CFR. We talked a little about today. There was a question about 42 CFR. There were 2017 revisions to the code that made it a little easier to share information with healthcare providers, and that's such an important part of your work as we work with you to engage healthcare practitioners, if you will, maternal and infant healthcare providers and hospitals around developing and implementing plans of safe care. And so, we'll cover overall 42 CFR. We'll spend some time talking about how that information can be shared between substance use disorder treatment providers and healthcare providers, both infant and maternal healthcare providers, and certainly including hospitals. On December 12th, we're planning a webinar that Jill Gresham, that you met Jill at the All Sites meeting, around plan of safe care implementation and a focus on local implementation of plans of safe care and examples that jurisdictions around the country are using to develop and implement plans of safe care. So included some examples of plans of safe care, as well as some examples of strategies to roll out implementation of plans of safe care, and some of the considerations for county-administered child welfare systems are looking at when they look to develop plans of safe care and address this issue for their families in a state that has county-administered child welfare systems. And then we've been recently in contact. Several of you have requested follow-up from Dr. Chasnoff's presentation at the All Sites meeting. So we've confirmed with Dr. Chasnoff having a webinar on February 6th. And now we're calling it a follow-up discussion with Dr. Chasnoff. We're going to be working with IRA to develop the content and include some of the content we included in the All Sites meeting. But we'd like to hear from you. We want to use this webinar with Dr. Chasnoff for you to invite your healthcare practitioners, particularly pediatricians, but not limited to pediatricians, nurses, hospitals. Invite them to this webinar. Give us some feedback as to what you think would be helpful for them to hear from Dr. Chasnoff. Certainly include some of the information that Dr. Chasnoff presented at the All Sites meeting, but we just don't want to have a repeat of that. Dr. Chasnoff is working with a couple of states right now that include quick sites, and certainly he can talk about screening and a couple of the agencies that we know they're using 4Ps plus, but give us some feedback as we shape that webinar with Dr. Chasnoff to meet your needs and to help you use it to engage your healthcare providers in your community. That is really pretty critical to the development and implementation of plans of safe care. And then we've got the listing of resources that are available to you that speak to the content that Lynn presented today, and certainly speaks to the work that you're doing as demonstration sites for the Quality Improvement Center for infants affected by prenatal substance exposure and their parents and caregivers. And you see the National Child Traumatic Stress Network, National Center on Substance Abuse and Child Welfare that we operate, the Children and Family Futures operates. When we talk about evidence-based practices, this is probably the standard for researching the level of evidence in particular interventions. And that's the California Evidence-Based Clearinghouse for child welfare, particularly since SAMHSA is no longer maintaining the NREP database for evidence-based practices. This is pretty much the go-to place for looking up evidence around different interventions, particularly grounded in child welfare. And then certainly the Child Welfare Information Gateway has lots of information around the things that we're talking about, and certainly child welfare practice as well as collaborative practice. And we've given you Lynn's contact information. With that, we wish you all a good rest of the week. We hope to see you on October 30th for the next webinar. And again, feel free to send Lynn questions or send us questions that may be triggered as a result of today's webinar, as well as if you have suggestions or needs around additional technical assistance or other webinars that we may be looking to put together. Feel free to let us know, and we appreciate your feedback and input. We thank you for your time today. Lynn, thanks so much.
Thank you. Thank you, everybody, for participating.
For being here, and we look forward to meeting again on October 30th.
Yes,
Bye,
we do.
everybody.
Thank you, Ken. Thank you, everybody. Bye-bye.